Hello, everyone. My name is Annie Reyes. Next slide, please. We're pleased that you could join us for this week's lecture in Volume 3 of our 12-week Neuropsychology Didactic Series that brings you lectures from experts in the field covering different topics each week. Next slide, please. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. Next slide, please. We would like to thank our sponsors for their financial support for this series. Next slide. Before we start, here are the disclaimers for the series. The training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Next slide. Questions can be submitted via the Q&A box on the lower left of your screen, and recording of today's lecture will be provided on our website later this week. Next slide. And now it is my pleasure to introduce Dr. Cristina Roman and Stephanie Torres for today's lecture on disparities in neuropsychology, examining the past and present and what's possible for the future. Dr. Cristina Roman is currently a postdoctoral fellow of neuropsychology at the Warren Alpert Medical School of Brown University. She was born and raised in Los Angeles, California, and completed her bachelor's degree at UCLA. She received her PhD in clinical psychology with a focus on neuropsychology from Pennsylvania State University in 2019 after completing her predoctoral internship at the Charleston Consortium. Her research and advocacy work today have focused on the structural neurocorrelates of cognition and mood in multiple sclerosis and aging populations, as well as the impact of systemic and psychosocial influences on cognition and mood, brain changes, and access to neuropsychological and neurological care. In her free time, she co-hosts Bilingual Neuropsych, a Twitter account focused on disseminating bilingual neuropsych vocabulary and promoting cultural neuropsychology. Now it's my pleasure to introduce Stephanie Torres. Stephanie Torres is a fifth-year clinical neuropsychology doctoral student at the University of Houston. In 2013, she received her undergraduate degree in psychology with an emphasis in neuroscience and behavior from the University of California, San Diego. This summer, Stephanie will start her predoctoral internship at Harvard Medical School, Massachusetts General Hospital, with a focus on neuropsychology. Her interests are in the intersection of culture, cognition, and lifespan development in the context of health disparities. Stephanie's long-term clinical research aims are to address the underutilization neuropsychological services in culturally and linguistically diverse population and assist in the development of culturally sensitive neuropsychological assessment. In addition to this, she has a strong interest in addressing the diversity issues in the field of clinical psychology and aims to work towards strengthening the support for graduate education and diversifying the psychology pipeline. And now, with further ado, I introduce Dr. Roman and Stephanie Torres.
Thank you so much, Annie. And so we're really excited to be here, and we'll go ahead and jump into discussing disparities in neuropsychology from the perspective of the past, present, and what's possible for the future. Before we get into the presentation, we want to say that we stand in solidarity with these groups and our hearts with the victims of the recent mass shootings and the police victimization. So let's start off with our positionality. So we're going to talk about our personal positionalities just because they reflect our assumptions. They reflect how we basically navigate the world. For me, I'm Chicana. My ancestry is from indigenous Mexico and also Spain. Both my parents were born in Mexico, and you know, my values that I grew up with and that I hold very dear are family, community, hard work, and integrity. As with everyone, I have had my adversity in my life and also privilege, and that has impacted how I see the world and how I navigate through the world.
Hi, everyone. So Dr. Roman and I actually have a lot of overlap. I'm also from Southern California. I'm from LA. My ancestry is indigenous Mexican, specifically Zapotec, and also on my dad's side, I have Spanish descent. I came from a family that worked mostly service industry jobs, grocery stores. A significant portion of my family was undocumented. And although I did go through many adversities, there was also so many privileges that I had. I grew up in a multi-generational household. I'm bicultural, bilingual, I'm cisgender, able-bodied, and so many other things. And so I'm coming from this specific, with these specific experiences, and that's kind of what shaped my view.
So our talk is about disparities, and not just focused on health disparities, but disparities broadly in neuropsychology. So disparities that occur in assessment, patient care, training, and also research. Merriam-Webster defines disparity as a noticeable and usually significant difference or dissimilarity, an inequality, discrepancy. Now, I'm going to primarily focus first on the past, and I have present here in parentheses because unfortunately, the present is often not so different from the past. Before I start, I do want to say that some of the things that I will talk about in terms of the history of medicine, psychology, neuropsychology, there are some triggering things that I'm going to discuss. And so I definitely want you to prioritize your mental health in yourself. So if you feel like things can be triggering for you, then feel free to step out for the first part of the presentation. All right, so what history of psychology or neuropsychology did you learn? Think back to your high school, undergraduate, graduate courses. I actually did a look through a lot of popular texts of psychology, neuropsychology for this presentation, and I can tell you what's there. Spotlight on founders, which are often male and white, intelligence testing, test and battery development, normative data, lateralization, etc. But what's not often there? The fact that neuropsychology has roots in all of these things: systemic racism, the caste system, colorism, ableism, sexism, homophobia, a whole slew of things that are not often talked about, but that definitely build up and lay the foundation for neuropsychology and psychology as a whole. So this here I'm pulling up to basically set the stage of where the creators of intelligence testing and assessment were coming from. This is a quote from Lewis Termond, who is often highlighted in a lot of texts and histories of psychology and neuropsychology, in his book from 1916, The Measurement of Intelligence. In one of the quotes, and I will tell you that there are many quotes that I could have chosen from, but he states, "Their dullness seems to be racial. The fact that one meets this type with such extraordinary frequency among Indians, Mexicans, and Negroes suggests quite forcibly that the whole question of racial difference in mental traits will have to be taken up anew and by experimental methods. When this is done, there will be discovered enormously significant racial differences in general intelligence, differences which cannot be wiped out by any scheme of mental culture. From a eugenic point of view, they constitute a grave problem because of their unusually prolific breeding." Many founders of assessment and intelligence testing were eugenic psychologists, Terman included. And historically, assessment, intelligence testing were used to prove differences between groups, essentially who was superior and who was inferior, most oftentimes favoring individuals who are white, cisgendered, able-bodied. These inferior individuals were often noted to be feeble-minded, defectives, morons, and this assessment and intelligence testing was often used to basically prove biological determinism. Things like the mulatto hypothesis, or the inferiority of indigenous individuals, Black and African-American individuals, Mexican-American peoples, to promote anti-Semitism, etc. And findings contributed to major decisions for marginalized groups, things like school segregation, immigration policy, sterilization, vocational fitness, even things like criminality and morality, and who was most fit to receive good health care. Neuropsychology has its roots in medicine, it has its roots in psychology. We are guided as neuropsychologists by the Houston Guidelines, but as Dr. Rivera Mint pointed out in 2015, there's a lack of emphasis on cultural competence in the Houston Guidelines. In fact, out of 2,035 words, only 11 were culturally relevant. Why is this the case, right? In addition to the history and all of the isms and oppressions that I noted in the previous slide, Eurocentrism has been the standard, right? White, cisgendered, able-bodied, etc. And our current tests and batteries that were largely developed with this particular population in mind. And this is what we've used, right? This is our norm. When we think about studies historically, we compare groups to this Eurocentric populations. But this is a problem for a lot of reasons, not only because it proliferates oppression and systemic racism, but it's also problematic because we know that culture is a known influence on brain development, cognition, and how individuals perform on the tests that we hold so dear. And normative data has also been lacking, which can lead to incorrect classification or misdiagnosis. And so why might this be the case? Why might there be tests that are racist, ableist, sexist, trauma-inducing? Dr. Desiree Bird in her recent paper discusses this primarily in the context of the Boston naming test in the noose. The noose has historical roots in lynching. It's been designated a hate symbol targeting African Americans by the Anti-Defamation League. And it's still used to this day, right? It's been historically used, but still used to this day as a symbol of intimidation, of violence. And, you know, she has a great quote that says, the original selection and retention of this item throughout the professional review process is where structural racism and psychological assessment intersect. That there's been a blind and automated acceptance, right, to respect standardization. This is the way things are. And to avoid retribution, right? That there's a lot of consequences that can come up if you speak up about these things. And so there's been this professional complicity that's occurred within neuropsychology to basically proliferate these views. Similar is the case with patient care. So health disparities are rampant in the United States. That's been the case for centuries. And there's a long history of minority groups, especially Black African-American communities, being exploited through care. So for example, care clinics being used as a proxy that they're, you know, it's low income, here are clinics, come, let us help you. But when they get there, they're used for experimentation opportunities, right, to test out new treatments. And because of this, there's mistrust due to centuries of exploitation. The same is true for the diagnoses that we use. So diagnoses and treatments have been used as a means to prove inferiority or to marginalize or oppress. Think of, you know, the DSM, the first 2 DSMs, including homosexuality, and hysteria and insanity in women was also something that was often diagnosed. And these diagnoses fueled treatments such as conversion therapy and lobotomies, which most often took place in women. But there's also the patient experiences. And these words, you know, it doesn't even start to describe what patient experiences have been in psychology, neuropsychology, but individuals feel unwelcome. They feel invisible, ignored, judged, rejected, second class. And we think about, well, were things in place to change this historically? You know, looking at that list of questions in terms of providers of similar backgrounds, individuals who speak their language, tools and tests and measures created to provide equitable care. The answer across the board is no. There's also the question of who refers individuals, right? So historically, who is referred to neuropsychology? A lot of times specialties. Who's most often in specialties? Those individuals who are white, upper class. Minority patients often work with primary care providers if they can get to that point. And oftentimes they're not referred for the care. And that's been the case over time as well. Now, getting into training and professionals, higher education. Individuals from minority groups, especially minority women, have not always been eligible or welcome in higher education. And I use welcome, you know, I think that can still be argued to this day. Now, the institutions that have some of the top clinical psychology programs, who have some of the top neuropsychology programs, if you look back in their history, oftentimes there was a time where they did not admit individuals from minority populations. They, you know, excluded these individuals and excluded women as well. And when individuals from racially, ethnically, culturally, and gender diverse get to the point where they can attend higher education, there's a lot of barriers that have been put in place because of the system. So oftentimes higher education is cost prohibitive. There's a lot of microaggressions. There's punishment or rejection for a lack of assimilation. There's sexual harassment occurs or mental exhaustion. There's the minority tax that occurs, especially with trainees. Having to negotiate these multiple identities. All of these things contribute to barriers for individuals from these backgrounds to go into higher education. In addition to that, our curriculum is colonized. If you did not get a chance to watch the Columbia Teachers College training on decolonizing psychology, I highly recommend it. It was amazing. And, you know, they talk about this. They talk about how our curriculum was colonized. In addition to that, you know, multicultural issues, once they started to actually be required in programs, they became add-ons. They became a checkbox that individuals had to, you know, that programs could check off to make sure that they met criteria for accreditation. But they weren't integrated or they weren't focused on as something that's important. In addition, the field falls short due to insufficiency of training. And this comes from who were the gatekeepers, right? If we think back to how I started this presentation, those were the gatekeepers of psychology and neuropsychology. And those views continue to be gatekeepers. And so ethnic minorities in particular are horrendously underrepresented in neuropsychology, and especially Latin and Black women have been significantly underrepresented in STEM fields. And women's experiences also have been, you know, a lot of trials and tribulations. Gender bias, the crazy bitch narrative, the angry Black or brown woman, you know, more debt coming out of graduate school, that they're less likely to be in leadership roles, yet they take on or have more work, sexual harassment, microaggressions, all of these things have affected women's experiences. And these things become even worse if that woman is from a minority background. Now let's talk a little bit about research. We cannot discuss research in any context, whether it be research generally, research methodology, without acknowledging the centuries-long history of experimentation on African-American Black individuals. In fact, you know, the dual face of American medicine by which health disparities owe so much, right? It's because of this that contributes to health disparities even to this day. And if you look there on the right side of the screen, you can even see quotes from notable individuals, Public Health Service, Tulane Medical School, and how they view individuals from African-American or Black backgrounds, right? These individuals were experimental animals. They were not human. And that is something that has definitely impacted research in psychology and medicine, and to this day. Here it carries on. So empirical evidence for group differences, right? This is something that's really focused on. And despite that, there are suspicious stats that occur, but none of these things are talked about. None of these things are included in the history of psychology or neuropsychology. None of these things are in the textbooks, with the exception of a few that are specifically focused on these issues. And there's this mistrust of researchers and institutions for good reason, right? We think about the centuries-long oppression. We think about the marginalization. We think about the experimentation. Yes, there's mistrust that occurs. But it's also the language that's been used historically, right? As to why individuals of minority backgrounds do not participate in research. They're paranoid. They're hard to recruit. There's also this lack of differentiation versus participation and enrollment, right? Participation puts the fault on the participants when that should not be the case. Instead, we should think about it as enrollment. What are we doing as researchers? What have we been doing as researchers to enroll individuals from diverse backgrounds? In addition to that, our research literature, right? There's only so much that we can take from that, yet we oftentimes think of it as gospel, because the study samples are not racially, ethnically diverse. They have not been. And the standard has been Eurocentric or weird, when racially diverse individuals or just diverse individuals in general are included in research. Oftentimes it's for that specific purpose. But, you know, overall, lack of diversity there. And there's also a lack of generalization in terms of aspects of what studies are generalizable to. I actually just submitted an abstract to NAN that looks at this in a particular neurological population in terms of what racial demographics look like over time in terms of reporting and generalization, and it's not good. So let's go ahead and jump to the present.
Thanks, Christina. Thanks, Christina. I'm going to be talking about the present. Next slide, please. So before I get started, I do ask that anyone who is watching take a moment to kind of reflect and let everything, all the knowledge that Dr. Roman has dropped on us kind of sink in, and ask ourselves how much of this remains true in 2021. Really, what has changed? Some of these things, as I was hearing her speak, I was like, yep, this. A lot of it sounds all too familiar in terms of research, in terms of how it impacts patient care. And something that is very close to my heart is, let's talk about graduate training. Next slide, please. So before I get started talking about research, let's take a quick snapshot of the demographics of the United States. So these were demographic trends of from 2020 to 2018. And if we note that a fair number of the US population speaks another language other than English, is not Hispanic, it's Hispanic or Latino, is foreign born. So increasingly as time goes by, our population has gotten increasingly diverse. And that's why AACN has their Relevance 2050 initiative. We need to stay relevant. We need to develop norms. We need to develop tests that are sensitive so that our population we can test them and be accurate in our assessment. Next slide, please. So last year, we published a critical review looking at the demographics of variables in neuropsychological research. So in this article, we actually reviewed over 1,600 articles from 7 well-known neuropsychological journals. And we coded for things like age, sex, years of education, race, ethnicity, SES, language, and acculturation. And this is actually a follow-up of a previous review that was done roughly a decade earlier by Dr. Sid O'Brien. Next slide, please. And similarly, when we're talking about comparing the past to the present, what has changed since Dr. O'Brien's review? There have been improvements. So here we have a table that is basically a summary of what our findings found, that there have been improvements in the report of a number of different demographic variables in populations. So anything that has an asterisk means that there was a significant change and that there were improvements, with the exceptions of, I believe it was SES, which might have gone down slightly. And one of the things I do want to point out again is that let's look at what variables are not being accounted for when we're publishing. We're not assessing acculturation. If we're thinking about our population becoming increasingly diverse, acculturation is not just people that might be immigrating from another country. Sometimes even within diverse communities, it might feel like they are in their own little niche, their own little community, even though they are technically in the US. So going from those spaces into other spaces that they're not familiar with, there is some level of acculturation that may happen there. So what we noticed is that acculturation wasn't even accounted for, not even 1% of the time in all of the journals that we reviewed. Standard things like gender, education, and so forth were reported, had higher levels of being reported, but there were a number of other factors that were not reported. And one of the things that we were talking about in our review, in our discussion, was the importance of really better characterizing our samples whenever we are conducting research, because again, next slide, please. It's important for representation and generalizability, like Dr. Roman was saying. If we're conducting research and it's predominantly white, is this information really generalizable? Does it apply to other groups? Also, in not reporting and better characterizing your samples, transparency. So one of the things that I've heard before is like, oh, but my whole sample was white. Like, I don't want to report that. The reviewers might reject my article if it's 100% white, so I just won't report it. We also need to reduce the idea, like reframe ourselves and think of it as we're being transparent, we're being honest. And it's important to be transparent about what research we're doing, and also justify, why was this the case? Why did you choose to use a convenience sample? Just kind of reflect on those things and mention it in your discussion and make that the norm. So with our study, we noted that 75% of the samples, of the studies that did report ethnic background, the median proportion of the non-Hispanic white participants were 75%. And let's think a sec. Can we really characterize a representative brain with this, with 75% being non-Hispanic white? Also, can we develop culturally and linguistically appropriate assessment tools with these weird samples? Next slide, please. And this is important because research informs clinical care. And clinical care also informs research. And so if we have this loop where most of our participants in research are white, then the development of measures that we are creating in research settings that might be used in clinical settings are not appropriate. And we have to think about that. We have to think, I believe someone raised their hand. Oh, sorry. We have to think about how that is going to impact our patient care ultimately. Next slide, please. So patient care. So with regards to what is going on, as Dr. Roman had mentioned earlier, historically underserved groups are less likely to seek neuropsychological evaluations. Often that might be because they don't know what neuropsychology is. I know for me, I didn't know what neuropsychology was until I was an undergrad. And many of these folks don't know the benefits of neuropsychology. So when I take a step back and I think about a number of the patients that I see that are from underrepresented backgrounds in clinic, the number of times that I've had a patient come in and we ask them, why are you here today? I don't know. They just referred me. And interestingly, even some folks are unaware that they're getting a neuropsychological evaluation because they might be a surgical candidate, which is even more alarming. All right. Also, there are barriers in access to healthcare. So what I mean by that is a lot of folks don't have insurance. A lot of folks have variable access to, or don't have the financial means to pay if they don't have insurance. As most of us may be aware, neuropsychological evaluations, if you pay out of pocket, are thousands of dollars. And that can be rent for some folks. That could be many weeks worth of food. And we have to think about these situations, how that might impact the fact that people might not be able to afford an assessment, even if they want it. In one particular situation, I actually experienced this where I had a patient who came in for an evaluation and they asked me, oh, is feedback optional or do I have to pay for that too? Because they were paying out of pocket. So every additional thing is an additional bill. And this was someone who had a neurodegenerative disorder. So this was really important to her. She wanted to know, what does this mean? And so forth. Another thing is, a lot of folks need a referral, depending on what kind of insurance or what kind of Medicaid, Medi-Cal, or what kind of insurance form people have. Sometimes they need a referral from their PCP. Other times they need a referral from a specialist. And especially in terms of lower socioeconomic status folks, people that might be single parents, each additional appointment is an additional day off work, which can be really hard. And these appointments are not 30 minutes, an hour. The number of times also that we sometimes have patients come in thinking that this is a standard doctor's appointment, thinking that it's only going to be a 45-minute tops appointment. It happens all too often, unfortunately. And more importantly, there are a limited number of providers who are trained to handle cultural complexities of diverse groups. So it's very limited, the number of folks that are linguistically diverse and can assess these individuals if they are linguistically diverse in their native tongue. Ideally, when assessing a patient who doesn't speak English or speaks another language, you want to use the appropriate measures. Also, having a professional that can assess in the native language is ideal, because sometimes, as great as interpreters can be, there are also limitations in terms of how long evaluations go when you are using an interpreter. Also having a reliable interpreter. So each additional thing that I'm saying basically just adds an additional barrier and can make it harder for folks to get a neuropsychological evaluation, understand what the benefits are, and follow through with it, further exacerbating already existing disparities. Next slide, please. So in terms of there are lack of diverse providers that can provide care to address disparities in neuropsychology. There's a call to action, and these calls to actions aren't new. In a quick search earlier, this has been going on for decades, where there have been call to action to diversify the recruitment of folks from underrepresented backgrounds in graduate school, not just even within psychology. But when we think about this as great as like, let's open the doors, let's let everyone in, we have to take a step back and really think, we're bringing students into spaces where they are not represented. We're bringing them into spaces that were not made for them in some cases. And we also have to think about our faculty being trained to mentor diverse students. Because people come from different backgrounds, we talk about cultural competence with patients, but there's also cultural competence between mentors and mentees. Next slide, please. So we talk about education and training. We talk about recruitment and retention. Some barriers to recruitment and retention of folks from diverse backgrounds that contribute to disparities in neuropsychology includes the fact that our stipends are really low. It's hard to exist. Sometimes I jokingly say it's expensive to exist, and our grad school stipends make it really hard. Also there are limited funding opportunities. Some of the things that I can think about is I was very fortunate at the University of Houston. I received a fellowship, for a diversity fellowship, for my first 2 years of being a graduate student here, which was great. And I know that's not, from speaking with other colleagues, I know that isn't always the case across other universities. Another limitation is also the GRE, which we can have a whole lecture on, but studies have shown that the GRE is another barrier to recruiting diverse individuals. There's limited exposure to neuropsych prior to grad school. Like I had mentioned earlier, I personally did not know of neuropsychology until I was an undergraduate. Also, the lack of mentorship from faculty who get it. And what I mean by get it that one, sometimes it's rough being a grad student and you're broke. You're the only person of color in the room. Sometimes you experience a microaggression and you have those moments when you think, wait, did I interpret that? Was that what they said? You have those moments of doubt. So sometimes having that lack of mentorship with faculty that understand what it's like to be a person, whether it's being a person of color, being someone who is of a background that is underrepresented in a specific field, can make a world of a difference. And a recent study, and I'm sure many folks might have seen, that there was roughly folks who are academics, who are already faculty, at least half of them, and this one was specifically within psychology faculty, at least one parent with a graduate degree. And a lot of folks who come from underrepresented groups don't have that. And we talk about lack of mentorship in terms of a faculty member, but there's mentorship even from, this intergenerational wealth. Also, let's talk about their traumatizing and invalidating interactions that a lot of folks might experience when in graduate school. And in experiencing these repeatedly, these microaggressions, sometimes macroaggressions, or just blatant racism, even from clients, from faculty, their students are at increased risk for depression and anxiety, making it more likely that the thoughts of dropping out or not continuing their studies might become something that it happens more often than it should. Next slide, please. And clinicians from minoritized backgrounds are also something to think about, when we're talking about education and training and recruitment from these groups. They're more likely to practice in underserved areas. They're likely to have patient populations with higher percentage of minorities than white colleagues. So there was a study done by Smedley et al., and this was in early 2000s. And there was research that has been done since then that has shown that this has consistently been the case, that folks from underrepresented backgrounds often give back to their communities. So when we talk about wanting to give back to our community, I know that's a big thing for me personally. You also think, we want to recruit these people that want to give back to their community, but we have to think what specialized training is available for those trainees who come from these communities, especially when a lot of the training and a lot of the curriculum is colonized, is Eurocentric. It was originally developed in white populations. What can we do so that these folks can be prepared to really serve these communities in need? Next slide, please. So now we're going to talk about what's possible for the future and a few recommendations.
All right. So, it can be a course on strategies for reducing health disparities, and just the history, the past, present of psychology and neuropsychology. And so we definitely only scratch the surface of issues that are still rampant in our field. But here are some strategies that we came up with to get us started. So in science, health disparities research in neuropsychology is needed to convey new knowledge about determinants of brain health, right, and outcomes across different groups. And to keep in mind everything that we've talked about, right, about how to enroll these individuals. It's not about whether they're participating or not. It's about whether you can enroll them as a researcher. Again, take ownership of what's happening. Clinical practice. In order to reduce disparities in care, providers need to stay up to date with changes in practice. So, cultural adaptations, norms, critical of our measures, being okay to sway away when, there's something that's ableist, sexist, racist, and stray away from the standardization, right? Policy. This is a great quote that psychologists must be in the room at the table, at the head of the table when policies are formulated and implemented. And of course, this is thinking about the intention, right? So the good intentions of how psychologists can help and trying to stray away from what our history has been in terms of policy and advocacy. Understanding and acknowledging health disparities in general and acknowledging that it's systemic, okay? That this is due to systemic racism. That's it, end of story. And, increasing multicultural awareness and knowledge, including anti-racism in there, cultural competence, humility, understanding the impact of racism on mental health overall, increasing multicultural education and training, mending that broken pipeline in neuropsychology of getting trainees into psychology, decolonizing the curriculum, increasing multicultural neuropsychological research, increasing the provision of culturally competent neuropsychological services to ethnic minorities, applying a model of treatment initiation, examining strategies for promoting patient activation, self-efficacy and engagement in racial and ethnic minority individuals. But again, as providers and as neuropsychologists, we also need to take ownership of what's happening and not put the faults or the onus on our patients. Thinking about intersectionality. Okay, so this is a critical framework for equity, and I think it's not talked about enough. It essentially examines how systems of oppression deeply intertwine and influence experiences and opportunities, that systems cannot be separated. A person walks through life with these unique interactions with these systems, and as a result, that influences basically whether they're receiving equitable care, equitable treatment, etc. And thinking about assessment in clinical practice, so culturally appropriate tests and normative data, but also considering the advantages and disadvantages of separate norms, allowing for diversity in our field. Okay, so not only active recruitment, but when they get there, allowing them to be themselves, right? So not forcing them to conform to the majority, not punishing them for not assimilating to what academia should be. Understanding and working against professional complicity. Okay, so this is also, in addition to the Boston naming test and what Dr. Bird brought up, but also just our tendency to want to stick to strict standardization, even when that might not be the best thing for trainees, that might not be the best thing for patients, and not penalizing advocacy and social justice efforts. When individuals do speak up, when they try to make change, don't penalize them for that. And creating clinics that focus on culturally holistic approach, right? The person as an individual, not just someone coming through the door who you have to test and have to spend extra time now on because they don't fit into the norm. Reimbursing trainees and providers for doing the work. There are providers and trainees out there who are putting in extra time, extra effort, who are doing the work so that patients can have equitable care, so that trainees can have a better experience, and they need to be reimbursed, they need to be recognized. connecting with the community and primary care providers, right? Trying to minimize that gap into who gets referred to our services. And this one is, I think we so often focus on what are we doing, right? You can be a program that's saying, well, I'm doing this and we have this and we have this, but I think it's important to step back and think of, okay, what are we not providing our patients and the community at large? What are we not doing? And that in itself can make us think differently about how we approach neuropsychology. Turning to groups who are also doing the work, who are offering safe places for diverse individuals. And that's not to say that, you throw the work on them and expect them to do everything and they carry the burden. That's not what I'm saying. It's turning to these groups and seeing what they're doing, learning from them, talking to them, listening to them. That's all very important. And also thinking about how we can change up the batteries that we use, the tests that we use. Here's an example of the African neuropsychology battery, where they changed up tests to be more culturally sensitive, culturally relevant. It's possible, we just need to do it.
With regards to education and training, to diversify our pool of applicants so that they can eventually they can also get their degrees and then serve these communities, holistic graduate application review is ideal. Rather than relying on things like the GRE and the GPA, which are known to be racist, and also negatively impact students that come from under-resourced backgrounds. Also increase graduate student stipends. Offer graduate tuition fellowships. Also, something very important, require anti-racist supervision and mentorship trainings to all faculty. And this is at a minimum to those who mentor students, and increase accountability. I've seen this where faculty who are well-funded, they bring on all the grants, they can not have to attend certain trainings, or I'm too busy, cannot do this. And I'm a firm believer, and this is my personal view, if faculty don't have time to attend these trainings, then they don't have time to mentor students, in my opinion. Specialized seminar courses for diverse trainees as an elective to build competency and better serve these communities. And part of the reason I say this is because, as Dr. Roman had mentioned earlier, a lot of with the minority tax is real, especially for trainees who want to give back to their communities that they come from. Oftentimes, because we don't have diverse faculty, we don't have mentors that may not be as familiar with the norms, with the cultural nuances when working with certain groups. A lot of trainees have to do this on their own, purchasing expensive books, going into the literature for hours and hours to try to see what is the best way to do this, because maybe they don't have mentors who they can reach out to. So having the opportunity to offer within universities specialized seminar courses, whether it's practicing a clinical interview in Spanish, there's colloquial Spanish, there's professional Spanish. I know for me, that's been an area of growth for me that I've been working on. And I've talked to many trainees that expressed interest in this. So whether it be through the professional groups, ideally universities would do this, but definitely this is something that I know from speaking to many trainees is an area of interest. Next slide, please. Also research. Acknowledge and address the racist history of research that contributes to the fuels to the distrust of these communities when it comes to participating in research. And also as PIs, as future, whether it be clinicians or future researchers, self-reflect on your own work, on the work of your PIs. Look in the labs that you're applying to. See if there are people that are diverse, because there was a study that was done that looked at diverse groups within research labs are often the most productive and more cited papers. So there are benefits. Some PIs take a step back and reflect, is there a trend between all my trainees? Am I recruiting a kind of copies of each other, where they all kind of meet a same certain criteria? And reflect on why that it is that you prefer these types of students. Also, conduct research that is relevant to the communities that you are serving. Establish partnerships. And going back, diversify your authors, your collaborators. And also for journal editors, if you're editing journals or you are a reviewer, ask whatever author's work you're reviewing, can you better characterize your sample? Provide, and you can refer to the paper that we wrote with Dr. Medina last year that was published for at least a minimum of these variables. Also refer to the JARS guidelines, the APA JARS guidelines. Next slide, please. So we end here with, without deviation from the norm, progress is not possible. So a lot of universities stick to what they're doing because that's been tradition. But a lot of that tradition is incredibly toxic, and it comes from racist roots. So we need to truly deviate from this and grow, because or else our field will stay stuck, and again, another 10 years will go by and we won't see any change, and the disparity will just continue to grow. Thank you.
Thank you.
Well, thank you so much both for this wonderful presentation. You took us into a whole history mode to learn about the racist ideologies of psychology in general, but just neuropsychology specifically, and how has that impacted our current research and clinical work. So we're going to take questions now. So if you have any questions, please include them in the Q&A chat. We won't be doing any live questions. I will be reading them and letting Dr. Roman and Stephanie Torres respond. So the first question that we have here says, I'm wondering what you have been doing personally as neuropsychologists to combat anti-Black racism and other isms in your clinical practice research teaching. That is, what does combating these systemic oppressions look like in practice in your professional lives?
That is a great question. So thank you for asking that. So combating racism is something that I'm very passionate about, and I'm a very active member within my diversity committee. I'm one that stirs the pot quite often, actually. And I ask these questions. I ask questions that might be a little hard sometimes for faculty to hear, or even other colleagues, asking, why do you say this that way, and so forth. And one of the things with regards to my clinical practice, actually, so thank you for bringing up this question, is I ask supervisors who might be white mentors who automatically assume, for example, like Black or African American. I have very good conversations when I ask questions. Why would you say, oh, did you ask them just because it's in the medical record? Or did we ask them? And then I've actually engaged in this has been incredibly rewarding, very rewarding conversations with supervisors that are receptive to feedback and wanting to learn. So I think for me, what has helped me kind of combat anti-Black racism within what I've been doing is I ask a lot of questions, and I try to do it in a way that is non-threatening, just curiosity. And that's, I always tell my supervisors, I'm someone that asks a lot of questions. And within my program, also just kind of talking about these things and bringing it up, talking about how it's important that we need to learn about the racist background of psychology, how psychology itself was racist in the beginning, and how we need to undo this. A lot of folks don't know. And I think like my goal has really been to just kind of talk about this whenever I can, to kind of help people's eyes open or force them to look at it.
Yeah, so it sounds like it's a very engaging and active process. Do you have any particular advice for maybe students who are just starting to navigate this? We know that there's this power differential when it comes to mentors and supervisors, directors of clinical training. So sometimes it's difficult for students to express. There might not be a grievance committee in their program. How do you, any tips or advice for students in those types of situations?
So yes, it's a very real thing, the power differential that occurs within academia and in our field. And I think that one of the things that's been really important, at least, and I can speak from personal experience, is finding your tribe. And that for up and coming, you know, if you're just coming into the field and you are a student of a minority background who maybe hasn't had as much exposure or access, you know, trying to find mentors of similar thought, trying to find mentors at different levels who you can talk to about these things. You know, it might be finding mentors for your peers to be able to talk about what your experiences are. It might be having mentors who are faculty at other institutions who you can ask for advice of, okay, I encounter this issue. Can we talk about what I can do if there is not a grievance process? Or if there is, you know, how do I go through this? And it's really just reaching out and trying to build your network so that you're not alone. And that's hard. It takes time. And I think being a graduate student can be really lonely. But that's one of the things that I've found to be very helpful and beneficial.
So one of the things that I've actually tried to do is similar to what Dr. Roman had said, is find your village, find your people who you can bounce ideas off of, people who are doing this work within their institutions. There are a lot of passionate students out there. Peer mentorship is real, and it's honestly one of the most rewarding things that I've experienced. Thank you, Twitter. Within this past year. So just even hearing other stories of other trainees and the work that they're doing, it empowers you. It also teaches you what language sometimes faculty are receptive to and not. Words matter, and how you say things can make a world of a difference. So sometimes, you know, bouncing back ideas with friends, mentors, and again, of different levels. Hey, I'm thinking of saying this, like bringing this up. What do you think? Asking for feedback and being open to that too.
Thank you. Okay, well, I see a comment and a question from the one and only Dr. Jen Manley. And she says, I am honored to be able to listen to this great presentation. First question is, how would you structure the settings in which neuropsychological training takes place in order to facilitate the goals that you express for diversifying neuropsychology?
Yeah, so in terms of restructuring the settings of neuropsychological training, I feel like it's a chicken and an egg. So I think first we need to diversify the mentors that are available. We need to diversify who's in the field. And I think that starts with really making changes in progress in the institutions. That's no easy feat. These institutions, we've been going against them for so long. But I think that, you know, in order to facilitate some of these goals that we expressed, it's really going to be, and some of the things that also Stephanie touched upon was, you know, removing or rethinking how we admit students, making sure that when they do come into programs that they do have a tribe or support system, making sure that there are mentors and sponsors that can help them and succeed in training. Stephanie, I'm not sure if you have touched this.
It all starts now. Thank you. Those are all great points. One of the things that I was going to add, even from the graduate application review process, even during the interview weekend, I think during interview weekend, something that our program has started doing is offering a safe space for students that are historically underrepresented in clinical psychology to have a space to ask questions to members of the diversity committee that maybe they don't feel comfortable asking in a larger group. We offer kind of like a buddy mentorships, like a brief mentorship opportunity during interview weekend where you can have the phone number of someone who has the same identities that intersect as yours as closely as possible, just to kind of hear what it is like at that institution. So those are a couple of things. Also diversifying the faculty, and as I had mentioned earlier, training faculty on how to mentor these students, and also empathize and understanding that there are limitations and broadening their view that they don't know everything. Sorry, faculty. There is no one size fit all model. One thing my mentor, Dr. Medina, says, he calls it the epigenetics of success, that in the right environment, anyone can thrive. And if you're in a bad environment, you know, no matter how great you may be, then that environment won't allow you to grow and to be the best thing that you can be. So doing that, and also even a buddy system within upper years and lower years. This is something that I know other graduate programs do. I don't know about psychology, but I know like within neuroscience here at Baylor College of Medicine, they have a buddy system to, again, expand the network, expand the village, because it makes a world of a difference. Let's see, how would you restructure our guild organizations?
So before you answer that question, I actually wanted to follow up on the comment about diversifying the faculty, right? Because there has been an increase, not a significant increase, but there has been an increase in the number of students from diverse backgrounds who are graduating with their doctoral degree. But as we heard in academic medicine, there is the leaky pipeline, right? Where there's a lot of particular physicians, it has been highlighted among physicians that they're leaving academic medicine because of the toxic environment, right? So I 100% agree with the both of you that we need to diversify the faculty, but it seems like it's more than that, right? Do we want to recruit more faculty in these toxic environments, as well as recruitment of students from diverse backgrounds into toxic environments? Or does it have to start with an approach where things have to kind of start from scratch, right? Because I think we might actually create more harm by bringing in these students, as you mentioned, in an environment that they may actually not be able to thrive, and that may actually be leading to trauma. Any thoughts on the leaky pipeline?
Absolutely. You make a great point. Thank you so much for bringing that up. And I think that it's not just about recruitment, but, it's about retention. And when we talk about retention, we need to think about the systems by which we're bringing these individuals in, right? If we're hiring faculty and we're bringing in all of these diverse individuals, but there's no change in the institution and there's no accountability, then that's, I think, where part of the leakiness comes out, for lack of a better word. It's one thing to recruit individuals, but it's another thing to create a safe space. And I think part of that has to do with accountability. I think, part of barriers of graduate students, trainees that they experience, and that has come out in the literature, is also harmful mentors and harmful institutions, harmful supervisors, and how that's playing into things. And I think part of that continues to proliferate because there is no accountability. There's no accountability for, tenured faculty who are pretty safe. And there's these things that are happening within the institution that I think need to be addressed and solved. And this goes to a point that I guess I didn't make during the presentation, is that this can't fall all on individuals of minority backgrounds, right? That the real change has to come with the majority, with the Eurocentric white institutions, that they have to buy in, they have to be willing to change, they have to be willing to make changes, they have to be willing to speak up. And I think that until that happens, that it's going to make changes to the institutions a lot harder.
Also change the tenure process. Pay faculty, diverse faculty who mentor these diverse students. So we talk as therapists, remember, even though we're neuropsychologists in training, we're clinicians, we're therapists first. Our degrees say clinical psychologists. So therapists need therapists. A lot of times faculty are hearing a lot of trauma that students are experiencing, and then in themselves, they're reliving their own traumas because they themselves experienced it. So a lot of burnout happens. And so the tenure process needs to change to some extent, where diverse faculty, if they are providing a lot of mentorship, for example, they should not have to teach as much. There needs to be another form, because that is highly valuable. If their presence helps retention of diverse students, then compensate them. Like, there needs to be a new way that the tenure process needs to be changed in that case. Also, embracing a collectivistic mindset also within these spaces. Within academia, there's a lot of very individual me. So I've talked with other folks, other faculty about this, actually, because I know I've struggled with this. I'm very collectivistic mindset. How sometimes it just feels like it's very individualistic, and that's not friendly to folks that might come from more collectivistic cultures. And that's also what's contributing to that exodus.
Yeah, and I agree. And I think especially, you know, us doing biomedical research, clinical research, and being clinicians, I think we have to remind, you know, who are we serving, right? This is meant to be serving our community, serving the people, not just serving ourselves and our career and our future and accolades. So I think I agree with you. We need a little bit more of that. So let's just go back to Dr. Manley's second question. How would you restructure our guild organizations like Division 40, NAN, INS to be consistent with the value that you expressed in your presentation?
Dr. Manley's throwing out those tough questions. That one I probably have to think about a little bit, but I think, you know, these organizations were built up in the system that I talked about when I talked about the past, right? And I think that because of the way that these institutions were built and the feelings of diverse groups across the years of going to them, that's, you know, one of the reasons why some of these affinity groups, these other groups, were built up. And so I think that the first thing is acknowledging what the past has been and where these institutions or these organizations have come out of. And I also think that, you know, it's really just foot to floor hard work in terms of making them safe spaces and making an effort to, you know, reach out to even very young academics, I'm talking high school, to make them knowledgeable and of science, of what's out there, to include them and, you know, start basically repairing some of the pipelines. But again, I think that, you know, that can definitely be a presentation in its own, and I don't have all of the answers.
So one of the things that, thank you, Dr. Manley, for this question. I think budgets can change within these organizations so that webinars are free for trainees, especially those pertaining to cultural competence and so forth, to allow trainees to have more access. We talk about having taking a more social justice approach, increasing accessibility to things, then we need to money talks. And money is a huge barrier for many students, as I talked about, low stipends, those expensive membership fees, whether it's the membership fees, whether it's having to pay for registration for conferences. I know it's lower than what faculty have to pay, but we also have to think of the amount we're paying relative to what stipends are. So that's something that comes to mind first to me.
All right, so it's 7:04. So I would just ask the question just to, are there any other maybe advice or tips for students who don't come from disadvantaged, marginalized backgrounds in terms of them starting this cultural humility journey, right? I think we could all agree that it's a process, it's not an end goal. Like many of our cultural neuropsychologists always say, this is a forever journey. We can never become an expert of any culture, including our own. So any tips and advice that you have for students, trainees, early career, even, you know, senior faculty who are looking to start on their cultural humility journey?
Yeah, I mean, I think educate yourself is one, right? If we're just sticking to the curriculum that's handed to us, you're going to miss a lot. Listen to individuals, listen to individuals from these marginalized groups, listen to your patients' experiences, you know, acknowledge your privilege, and be willing to do the work. So I think avoiding putting the work on others. So it's not going to, you know, minority groups or individuals and asking them, well, can you teach me, or what should I do? What am I doing wrong? You know, it's lessening that burden as best as you can. because these groups have a lot of burden that they carry with them.
One of the things that I know for me, I like to explore culture through food. So I think immersing yourself in different communities is really important. The more you interact with communities from different backgrounds, the more you learn to have an appreciation for the subtle differences. And the number of times that food has come through for me when connecting with a member, I know people know I love food, when it comes to connecting with a patient, just even those, especially when working with folks from diverse backgrounds, those small interpersonal interactions can mean the world. So trying to be as humble, being willing to learn, as what Dr. Roman said, sit back, listen and learn, and also have your colleagues back. I think more important is sometimes, as if you are, for example, someone who is Caucasian white, and you hear a colleague, you know, they're sharing their experience with you, vouch for them with their permission, of course, vouch for them, speak up. Sometimes if you are a person from an underrepresented group, a person of color, if you say something, you might be as the angry person of color. Unfortunately, who says what can make a huge difference, and taking that burden off of them.
That is perfect. As I always say that part of addressing health disparities is elevating, supporting members of these communities, students and trainees who initially started this journey to actually serve their communities. So that should also be part of addressing these health disparities, is elevating these trainees and early career folks. Well, thank you both. This was an empowering presentation and Q&A section. For those who are still watching, remember that next week we'll have our lecture on non-epileptic seizures and other functional neurological disorders. Make sure to tune in or watch our lecture on our website. Thank you both.
Thank you.